We are on Facebook right now, doctor. Thank you so much. I'm going to introduce you to the audience. Doctor, I'm going to speak in Spanish for a while, okay?
Okay, I can understand Spanish.
Very good. Thank you so much. Buenas tardes a todos. Muchas gracias por acompañarnos. Estamos nuevamente en un webinario de la Asociación Mexicana en Ultrasonografía Crítica y Urgencias. Estamos muy contentos y verdaderamente honrados porque tenemos al doctor Tomás Geeraerts desde Toulouse, Francia. Vamos a hablar en esta ocasión sobre el ultrasonido del nervio óptico, de la vaina del nervio óptico en la detección de hipertensión intracraneal, lo cual es un tema por demás interesante que genera mucha expectativa, mucho interés, sobre todo porque este tema es parte del programa que se hace en los cursos de Ultrasonography Life Support, de ultrasonografía en el soporte de vida. Es parte del currículum, ¿verdad? Del cual debe tener o debe formar parte en todo lo que es el entrenamiento de un médico en la ultrasonografía crítica. De tal manera que hoy tenemos a un experto mundial, al doctor Tomás Geeraerts, desde Toulouse, Francia. Él ha escrito innumerable cantidad de artículos, como ustedes pueden ver en su currículum. Recientemente él participó en un grupo colaborativo grande que está publicado justamente en el mes de marzo en la revista Intensive Care de la Sociedad Europea de Cuidados Intensivos sobre la administración de líquidos en el paciente neurocrítico. Es un estudio y un paper muy interesante que ustedes pueden visualizar ya en el sitio de esta revista. Y también recientemente participó sobre el manejo y dirigió un estudio también muy grande sobre el manejo del traumatismo craneoencefálico en las primeras 24 horas. Y de ahí una cantidad enorme de estudios en el paciente neurocrítico. Realmente estamos muy honrados, particularmente en este tema de la ultrasonografía del nervio óptico. El doctor ha escrito mucho, también es muy abundante su literatura, entonces incluso ha hablado de esto en los pacientes con preeclampsia, etcétera, en diferentes escenarios, por lo cual de verdad es un honor y ojalá aprovechen para cuestionar, para preguntar, para comentar todo lo que ustedes gusten sobre el tema en estos próximos minutos. Recuerden que la manera de participar a través de, y que quieran interactuar es a través de dos formas. Una de ellas es mediante la plataforma Zoom con el número que está publicado para que puedan interactuar, puedan platicar con el doctor, puedan hacerle sus preguntas en tiempo real, tanto con audio como con video. Y la otra es desde el chat de Facebook que en este momento se está transmitiendo. De tal manera que un saludo a todos, sean ustedes bienvenidos y vamos a pasar a la conferencia del doctor Tomás, que desde Francia, desde Toulouse, Francia, ha accedido amablemente a participar en este webinario. Muchas gracias. Agradecemos al doctor Tomás Geeraerts. Thank you so much, Professor. Welcome to Mexico. Thank you so much. Thank you for spending part of your time with us.
Thank you very much. I'm sorry, I'm not able to speak in Spanish, but I will try to do it in English.
Very good.
So I'm now working in Toulouse. I was in Paris before, but I'm now working in Toulouse. Toulouse is a city close to Spain, 1 hour from Spain, and southwest of France. So thank you very much for the invitation. It's a great pleasure for me to be here. And I have 30 slides, and maybe we can discuss after the slides, after the presentation. And the topic is ultrasonography of the optic nerve sheath for the detection of raised intracranial pressure. And I will also have some slides on brain sonography in general and mean line shift assessment using sonography. So I have no conflict of interest to declare. So I will not say that we should not place invasive ICP monitoring. It is a reference method, and we should place intracranial pressure when it is indicated. We all know that there is no strong evidence for benefit for patients, but nobody will manage a septic shock without an arterial line. And for a neurointensivist, I am an anesthesiologist and a neurointensivist, it is not possible to manage those patients without an invasive ICP. So please place invasive ICP in the most severely injured patients. However, we know that in approximately 50% of the patients, ICP is not placed, and the recommendation, the guidelines are not followed. And clearly there is a need for non-invasive estimate of ICP. At the early phase of brain injury, in stroke, in TBI, the first hours are mainly in non-specialized center, and mainly sometimes in the field during war or in small medical centers. There is a need for non-invasive ICP for early triage and detection of rise ICP, to identify patients that need diagnosis, investigation, treatment as osmotherapy, and transportation to specialized facilities. And also for therapy monitoring, for example, to follow the efficacy of osmotherapy. We all know the old fundoscopy that was performed to detect rise ICP in patients. We know for years that papilloedema needs several days to appear and several days to disappear. It is clearly not good enough for acute rise ICP detection. And it is interesting to see not the edema, but probably the eye and the optic nerve sheath. The optic nerve is surrounded by a dual sheath with CSF, with cerebrospinal fluid. And in case of no obstruction for the CSF, the pressure in the CSF is the same everywhere. And if the CSF is freely moving, in case of rise pressure in the sustentorial compartment, the CSF will move down and it will accumulate in this cul-de-sac in the retroorbital area. And if the pressure increase here, the sheath will dilate. We know that for years because there is a specific architecture of the optic nerve sheath. And just in the retroorbital part, the trabecula are large, and the sheath can dilate here, but it cannot dilate in the proximal part of the optic nerve sheath. And we know for years that when you apply, when you increase the pressure in the CSF using lumbar puncture, and you infuse fluid in the lumbar puncture, you increase the CSF pressure, and the optic nerve sheath will dilate like that. And what is interesting is that you can measure it very easily using sonography. It has been firstly published in 1997 by a Danish group. And when they infuse lactate, ringer lactate in the CSF, they have nicely shown that the pressure highly correlates with the optic nerve sheath diameter measured using sonography. So it was old sonography, so the quality of the image is not very good. And now thanks to increased quality of the sonography unit, the image are much, much better. And it is very easy to do. Just use a simple linear probe, place it on the eyelid, and measure it like that in one plane and in another plane. And it takes less than 1 minute. And after that, you have this picture. Here it's the ocular globe. Here in the what is hyperechogenic, it's orbital fat here. And in the center, you have the optic nerve and the sheath surrounding the optic nerve. And we always measure the distance like that. The first, we have to measure the distance between the papilla and in the axis of the nerve. And we always measure a transverse diameter, but 3 millimeters behind the papilla. So first measure, just check that it is 3 millimeters, and this measure, so it is as soon as the signal becomes hypoechogenic, so it is water or CSF, and here as soon as it is hyperechogenic, so fat. So it is very simple to do, and with the new sonography unit, the quality of the image is very good. I will show you another example. So it is a nurse and a resident. So do not induce pressure on the eye, and just place the probe on the gel, but without exerting pressure. One measure in one plane and another one in the other plane, and you will have some image like that. So optic nerve here and optic nerve here. We published several papers on the method. The first question was, what is the normal value of optic nerve in intensive care patients? And is it different in TBI patients with or without raised ICP? So it was published in Intensive Care Medicine 10 years ago, in fact. And we have done ocular sonography in control patient. Control patient was a patient in ICU, but without intracranial pathologies. So it was, severe pneumonia or something like that. So TBI patient with normal ICP means ICP below 20 millimeters of mercury. So ICP was measured with an invasive probe, so the reference method. And high ICP patient was patient with ICP above 20 millimeters of mercury. So the first answer was in control patient right or left ICP is around 5 millimeters of mercury, 5 millimeters. So normal value, 5 millimeters. What is interesting is that in TBI patients with normal ICP, it was also 5 millimeters. So no difference between control and normal ICP patients. But in high ICP patients, optic nerve sheath diameter was 6.2 millimeters of mercury. So just a simple memory, normal value, probably something like 5 millimeters. And high ICP patient, something like 6 millimeters. It is the optic nerve sheath diameter. It is not the diameter of the optic nerve. It is the diameter of the optic nerve and the CSF surrounding the nerve. So the correlation between the reference method, so invasive ICP and optic nerve sheath diameter, was acceptable. It is not a very, very good relationship between, I will discuss that later, but it was like that, and it was acceptable. What was more interesting that you can probably follow the changes in ICP. The delta ICP was highly correlated with the delta optic nerve sheath diameter. We will discuss also that because in some case, when the ICP was very, very high, something like 40 or 50 millimeters of mercury, and you've done something to decrease the ICP, and ICP decrease. But what you can observe is that the optic nerve sheath remains large. It is like a balloon that was overinflated, and the trabecula were probably destroyed, and the optic nerve sheath was not able to have the same size that at the beginning. And it is a sign, if the optic nerve sheath diameter is enlarged, it is probably that your patients have high ICP or had high ICP in the next, in the very, very previously time. So this patient is at risk of having a rise ICP and probably should receive an invasive probe to check the real ICP. So once again, it is the optic nerve sheath diameter that was able to discriminate patients with high ICP and not the optic nerve itself. It is not an inflation of the nerve, it is a dilatation of the sheath surrounding the optic nerve. We have published also a meta-analysis almost 10 years ago, and there are now more than 150 papers on the subject, and they all found that the sensitivity for detecting a rise ICP is high, 90%, and the specificity is acceptable, 85%. So if you have an enlarged optic nerve sheath diameter, the probability of having a rise ICP is probably around 90%, and this patient is at risk of having a real high ICP. So it is probably the new papilloedema sign using sonography. And we published this commentary in Critical Care with the analysis of the studies. Another interesting study, it was published 3 years ago, and showing that if you infuse osmotherapy to decrease ICP in this patient, and in some of them the ICP decrease dramatically, and the optic nerve sheath diameter also decrease after infusion of mannitol. So probably you can follow and check the efficacy of your osmotherapy in the most severely injured patient. Here again, you can see that in those patients, ICP was very, very high, and it is those patients where the optic nerve sheath diameter is not able to decrease, probably because it was completely overinflated and the trabecula was destroyed, as we discussed before. So I was definitely convinced by these optic nerve sheaths. When I was in Cambridge, I have done an MRI study using the same methodology to measure optic nerve sheath diameter. And in Cambridge, we put patients on MRI with an invasive probe for ICP, and it was very easy to correlate the optic nerve sheath diameter using MRI and invasive ICP. And the result was very, very similar to those we observed using sonography, with the same cutoff. Probably the cutoff is 5.7 millimeters to discriminate patients with or without ICP below 20 millimeters of mercury, saying that we have a patient with high ICP. Now I will discuss another interesting point to my opinion. It's in TBI patient we should place an invasive ICP, but there are a lot of pathology where we don't place ICP because it is not recommended. And in some of those cases, we can have a truly high ICP. The first question is, in preeclamptic patients, they have headache, they have nausea, vomiting, and the symptomatology can mimic symptomatology of rise ICP. The question, and there are some MRI studies suggesting that the brain edema can be important. And the question was, can we have, in some patients, argument to say that they have rise ICP? So we have done ocular sonography in preeclamptic patients, and in healthy pregnant women, the optic nerve sheath diameter was 4.5 millimeters. But in preeclamptic patients, it was enlarged and it was 5.4 millimeter. What was mostly more interesting, is that we followed those patients after the delivery. So here in white, you have healthy pregnant patients just before delivery. So normal value. Just before delivery, preeclamptic patients, and in the following days, you can see that the optic nerve sheath diameter progressively decrease, and at day 7, the value are similar to control patients. So probably progressive decreasing of right ICP and brain edema. So it was published in anesthesiology, and I think it's an interesting way of using ocular sonography in patients where you suspect right ICP, but where you will never place invasive probe. Another interesting study is acute mountain sickness. So in this nice paper, they climbed the Everest, and with a sonography unit. And they have measured optic nerve sheath diameter at 2,000 meters of altitude, 4,000 meters, and 6,000 meters. And then they have nicely shown that the optic nerve sheath progressively increase, suggesting that the ICP increase, and suggesting that in acute mountain sickness, in some patients, you can have brain edema conducing to rise ICP. So that was interesting, and you can probably use ocular sonography. Another interesting study will be to use it after cardiac arrest to check if there is some rise ICP, and maybe to adapt the treatment in those patients with rise ICP. But we probably need to perform this study to show that there is a benefit of monitoring ICP non-invasively using ocular sonography. Another interesting point is the contrary. It is not rise ICP, but it is intracranial hypotension. Intracranial hypotension is CSF hypotension due probably to CSF leak. It can be spontaneous, it can be after trauma or after post-dual puncture. And it is involved in the pathophysiology of subdural hematoma in cerebral venous thrombosis. In some patients, after post-dual puncture, they have some headache, and we have a blood patch should be performed to stop the leak. The question in this paper we published several years ago in the British Journal of Anesthesia. It's what is the effect of the blood patch on the optic nerve sheath, suggesting that if you correct the CSF hypotension, you will observe a progressive increase in the optic nerve sheath. So we perform ocular sonography before and after blood patch in patients suffering from post-dural puncture headache. And we have, it is a very small study in 10 patients. In 9 patients, the blood patch was followed by the complete resolution of the headache. So successful blood patch. And you see that, that after 10 minutes, 2 hours and 20 hours, the optic nerve sheath progressively increase. But in one patient, the blood patch was not followed by a success, so blood patch failure, and the optic nerve sheath did not increase. So probably the leak was still present. So it is another way of using ocular sonography to check for CSF hypotension and maybe to check for the success of your treatment. So the question of the methodology, the variability of the method can be important because, as I said before, the difference between a normal subject and a patient with rise ICP is around 1 millimeter. The probe precision using a modern probe is probably 0.1 millimeter. You should use a high frequency probe, so more than 7.5 megahertz, and the inter-observer variability is probably something like 0.2 or 0.3 millimeters, so acceptable. The learning curve is 25 examination with 10 normal and 15 abnormal exam. There are some pitfalls. The first pitfall is that the coronal axis of the optic nerve sheath is constantly less large, smaller than the other axis. Another artifact, you can see here, an artifact here. It is when you do sonography, you know that it is an artifact, but you should be aware that it can appear when you use ocular sonography. It is a linear line, a straightforward line that is not attenuating with the distance. It is a sonographic artifact due to cribla lamina, and you should not use these lines as the optic nerve sheath. So please don't use this line when you see that. You should have a better image and place the optic nerve in the medial part of your image. So the frequency of the probe should be high. You can use linear probe, so vascular probe is enough. You don't need a specific probe for that. And you should not insonate the lens through the lens, and you should have a visible difference between the sheath and the nerve. So we published this quality criteria with some guys, and what was interesting is that this guy is a guy from the NASA, from the US for me. And here also in Toulouse, we have some specific experimentation on astronauts. Because in this population, you can have headache and visual impairment. And the question is is it a rise ICP or not? And in fact, we have published a paper last year, and we have some strong arguments to say that using ocular sonography, in some subjects, they are susceptible with to spatial environment, and they can develop to rise ICP in the space, which can be a very important problem, that as they are not able to work and to do their specific task. So MRI screen, you can see that it is, what is white is water, so T2 weighted image, so water TSF is in white, and sonography, you can see the nice differentiation between the fat and the optic nerve and the schist. You should be aware that when you use sonography, and specifically sonography in the eye, you can have some potential adverse ultrasound-related effect. So please don't use a Doppler mode in the eye. Don't use color flow. Don't use low frequency, because it increases the thermal index and mechanical index, and in the eye it can be deleterious. There are some guidelines from the British Medical Ultrasound Society, and you see that, just check the eye, they recommend to monitor the thermal index and mechanical index, and then the thermal index should be less than 1, and the mechanical index should be less than 0.3. And if you use this setting, you will not have adverse effects. So please ask your manufacturers to set a specific mode for the eye with these parameters, so thermal index less than 1 and mechanical index less than 0.3, so you will be able to insonate the optic nerve without precaution. So just to finish and to extend the sonography to the brain, I will show you that we can nicely and very easily measure the midline shift using sonography. So we all know that the midline shift is a severity criteria and needs specific and rapid intervention from a neurosurgeon. More than 10 years ago, it was published that in malignant stroke, so massive ischemic stroke, sonography can be used to detect midline shift. It is very easy. Just use the probe and find the third ventricle, measure the distance between the bone and the third ventricle, and do the same thing on the other side. And the midline shift will be the distance B minus A divided by 2, and it was nicely correlate with a CT scan. We have done a very similar study and published several years ago in critical care in neurosurgical ICU patients, sorry. So midline shift here it is the third ventricle, very easy to find using sonography. So in the middle of the third ventricle and from the bone, and the same at the other side. And the relationship, the correlation between brain midline shift with sonography and brain midline shift with CT was excellent. And the Blunt and Altman plot was also acceptable. So it is probably a very good way for detecting a midline shift. And just this video to show you. It is a very similar way of using sonography for transcranial Doppler. So transcranial Doppler will be a little bit higher, like that. And if you go like that, you will see the third ventricle, and you will, will be able to measure the mainline shift very easily. So I think it's up to you now. Probably you should test it. And if you think more generally, if you use transcranial Doppler, that was not the subject of this topic, but being able to estimate the cerebral perfusion pressure, if you are able to detect rise ICP using brain sonography, and also able to detect mainline shift, significant mainline shift using brain sonography, you will be able to detect the three major pathological situation that need urgent treatment. So osmotherapy, surgery. So the question is clearly not to replace the CT scan, but it is probably to detect earlier those patients before CT scan or during transport to adapt the treatment. And we are currently running a study using sonography as a tool to adapt the treatment in the most severely injured patients. So thank you very much, and I will be very happy to answer.
Thank you, Thomas. Thank you, Professor Thomas. Thank you for your amazing conference. Well, we are going to move to the questions, if you allow me, Dr. Thomas.
Yes, thank you.
Ok. Bueno, chicos, no sé si hubiera algún comentario o alguna pregunta en vivo, lo podemos hacer en este momento. Estoy en nuestros participantes a varios médicos que han estado pues muy involucrados en el tema de los neurocríticos, como el doctor Arnulfo, que estoy viendo en este momento. Me gustaría escucharte, Arnulfo, acerca de tus comentarios. Voy a activar tu audio para saber cuál ha sido tu experiencia, ustedes en la unidad de entrenamiento allá en Guadalajara. Allá en Guadalajara ustedes seguramente hacen esto frecuentemente. Y me gustaría escucharte, Arnulfo, si tú nos permites ahorita. No sé si me escuches.
Hola, ¿me escuchas?
Sí, sí te escuchamos, Arnulfo, adelante.
Gracias. Sí, pues la experiencia que hemos tenido a través del tiempo realmente ha sido muy buena. Creo que hemos aprendido mucho del uso de la ultrasonografía en un paciente crítico, tanto de la medición de la vaina como la ultrasonografía Doppler transcraneal. Y pues es para nosotros muy útil ver cómo el paciente evoluciona, sobre todo esto, darle un seguimiento. Más allá del diagnóstico, que existe cierta controversia entre la correlación de si tiene o no hipertensión intracraneal, vemos mucho cómo el cambio de un paciente a veces nos lleva a una tendencia donde vemos claramente cómo el paciente se deteriora antes de tener un cambio clínico. Y esto para nosotros ha sido muy útil en los últimos años y bueno, vemos que faltan muchos estudios todavía para declarar ciertas cosas como de uso rutinario, ¿no? Pero creo que vamos por buen camino y pues hacer más estudios que aumenten el nivel de evidencia de la utilidad de la ultrasonografía Doppler transcraneal y de la ultrasonografía de la vaina, que me parece a mí muy útil.
Perfecto. Así es. Bueno, no sé si alguien más quisiera comentar, doctora Iris, no sé si quisieras comentarnos algo también de tu experiencia en los centros donde tú también te desenvuelves, lo cual es, seguramente también has tenido esta experiencia. No sé si alguien más del panel quisiera hacer algún otro comentario. Yo quisiera preguntarle al doctor un poco más acerca de lo que comentó de cómo la vaina del nervio óptico permanece grande, digamos, ensanchada, con un diámetro importante después de niveles altos de hipertensión intracraneal. Entonces, ahí me gustaría que nos comentara el doctor un poco más acerca de esto. Dr. Thomas, if you please comment some more about the follow-up of the patients, because you commented that when we have patients with highest intracranial pressure, maybe the optic nerve sheath doesn't recover the size immediately. So, so in this case, the optic nerve sheath diameter, so it is not so useful for the follow-up? Or what is the conclusion about this?
So if the patient underwent a very high ICP, and in my experience it is ICP less than 30 millimeters of mercury, so the optic nerve sheath will remain enlarged due to over distension and trabecular destruction. So it cannot be used, or it will take days or weeks to recover the initial size. So in this patient, you will not have an interest of using ocular sonography for the follow-up. But I think, in my opinion, it is a very, very severe patient. So these patients usually they should have an invasive ICP probe. So I think in those patients, it is not the question. In my hospital or in my pre-hospital team, we use ocular sonography as a detection tool to detect patients with rise ICP and to class them in risk patients for rise ICP or normal patients. And after that, considering also CT scan and clinical examination, we say that there are signs for severity, and these patients should go to the specialized ICU and have ICP probe in place. So it is more a detection tool. If it is normal, you can be reassured. Probably ICP is normal. If it is enlarged, please place invasive ICP urgently or infuse mannitol before having the real ICP if you are not in an hospital that is able to place ICP.
Okay, thank you, Dr. Thomas. And there is one more question in the chat. Can you see the chat, Dr. Thomas? Because someone is questioning in French.
No. Really, no.
Okay, chat and the lower part of the screen, there is a chat. No? Can you see?
There is not.
Okay. No, okay. Chat? No, okay. One person is questioning in French, but I'm going to translate in his, because he says in Spanish now after in French. Okay, the limit, he's questioning about the limit of the measurement, you know, if it is after the routine or it is before, some technical aspects. If you want to speak about this, please.
Yes. So, though the limit should be as soon as it is becoming hypoechogenic. So you have the fat hyperechogenic, and once it is decreasing, you should place the caliper there. And again, the same thing. My experience, and after years of using sonography, I don't measure the value anymore. I just place the probe and seeing the image, you can see it is enlarged or not. If you are not able to see water, CSF surrounding the optic nerve, it is a normal patient. If you have like a double line surrounding the nerve, you have CSF there, a lot of CSF, a lot of pressure, and the ICP is probably high. So for my students, I perform the measurements, but we can say this patient is not normal, this patient is normal, just seeing the image. And probably you need 20 examination to be able to discriminate those patients. So another important limit of the method is in patient with ocular trauma. So we don't use ocular sonography in patient with ocular trauma or with ocular pathologies like cataract or things like that. I don't know if the measurement is possible or not, but by precaution, we don't use ocular sonography in those patients.
Okay, thank you so much, Doctor. And can you emphasize some aspects, Dr. Thomas, about the pitfalls of the measurement? Because I think it is quite important, because when we are trying to measure or to do these measurements in the patients we are high intracranial pressure, maybe we should be cautious when we are measuring the optic sheath. And can you repeat briefly the pitfalls again of this measurement, Dr. Thomas?
Yes, I will. Maybe I will show you this slide. If you see something like that, a line straightforward that is not decreasing with the distance from the surface, it is not a true sonographic image. It is an artifact. It is a repetition of the echo due to repetition through the lamina cribla of the ethmoid. If you see these lines, very straightforward line, it is not the limit of the optic nerve. So you should probably place the probe more in the upper part of the eye and find a better image without this artifact. So this can be considered as the limit of the optic nerve sheath, but it is not. In fact, the true limit is probably somewhere here. And this Italian guide published a way of checking that you are in the optic nerve, doing Doppler and find the central retinal artery here, checking that you are really measuring the optic nerve. But I will not say that you should do that. It is interesting, but if you're not an expert in ocular sonography, please don't use Doppler because it can induce adverse biological effects. So if you're not an expert, don't use Doppler through the eye, because you can have some thermal effect here in the retina that you don't want, and some potential adverse effect.
Okay, doctor, thank you so much. And well, so talking about the correct measurement, Dr. Thomas, do we have to take into account the lens, or do we have to see the lens when we are doing a correct measurement? Or what are the right points that we have to see when we are measuring the optic nerve?
So no insonation through the lens. So because it can produce also some artifacts. So usually we insonate in the upper part of the eye, and the lens is lower. So we insonate very close to the bone here, and the lens is lower, and we have a direction from up to down to find the optic nerve sheath. Another difficulty is that sometimes the optic nerve is not straightforward. it can be it can have a sinuous direction. So especially if the patient is not sleeping, is conscious. So because if the eye is going up like that, the optic nerve will have this direction. So it can be difficult to insonate in conscious patients, but in my experience, usually we use it in a sedated patient. But it was a problem in this study using blood patch, and in the other study when we have done in ocular sonography in preeclamptic patients. So you should ask the patients to look straight forward without moving the eye, and sitting in the 30 degrees, very calm. And yes, it can be difficult in conscious patients. Sorry.
Okay, thank you, Dr. Thomas. So the recommended position of the probe, Thomas, does it, or is it longitudinal or transversal in summary?
Very good question. So at the beginning, 10 years ago, we were always doing sonography in this axis and in this axis, as I show you in this slide. Today, I'm just using this axis, the first one, because it is the results are very similar if you use one or two axes, and it is much more simple. So today I only use the horizontal axis, and we are doing the mean of both eyes. So sometimes you can see differences between right and left eye, but in most of the case, the ICP is similar between the right and left hemisphere. So so the optic nerve is dilated similarly. So today I'm only using one plane, one axis, and it is the horizontal axis, because it is a very simple axis to do, and it lasts less than 30 seconds to have an acceptable image. So that's how we do it today. And we have performed a study using this methodology in the pre-hospital team. As you know, in France or in Europe, I think also in Mexico, you have some SAMU team with a physician, emergency medical doctor in the pre-hospital, ambulance, and in my region we have some long distance between hospital and the major trauma center where I work here in Toulouse, and they use ocular sonography in the pre-hospital team, and the feasibility and the precision of the method is very, very good, even in a pre-hospital team with sonography units that are not very, very, very good. You know, it's this sonography unit that you use for general detection, general sonography, and not specialized for the eyes. So use the vascular probe, more than 7.5 megahertz, high frequency probe, plain linear probe, and only one plane, one axis, horizontal axis. It is probably enough to detect patients with rise ICP.
Okay, thank you. Thank you, Dr. Thomas. We really appreciate it. It's very, very interesting. I think there are a lot of physicians in the emergency rooms, in the operating room, in the intensive care units. They are interested in this topic, because I think there are some settings, as you mentioned, here in Mexico is the same, We don't have in all the hospitals, we don't have the invasive intracranial pressure measurements. So that's why this kind of tools results very, very important, above all in the emergency rooms and some settings where the invasive intracranial pressure is lacking. So
and I think also that in some pathology like post-cardiac arrest, and it can be very interesting. And also in the operating room, because we have published in PLOS ONE last year a study when you perform radical prostatectomy using robot assisted. The surgery lasts more than 8 hours and the head is down. And we have performed ultrasonography to see if there is rise ICP, and the response was probably not. There is no rise ICP in this position, even after 8 hours of surgery. So that was probably an interesting way also to check in some pathology where you never see ICP, or to check if there is a rise ICP or not.
Yes. Thank you, Dr. Thomas. And even in patients, for instance, in patients, in preeclamptic patients, in Mexico, there are a lot of preeclamptic patients, and that it results very, very useful for the physicians who are in the austere settings, you know, because we have the preeclampsia in Mexico is a huge problem. So that's why it results it is a very important tool in those kind of settings. Well, Dr. Thomas, thank you so much. The webinar is over right now, and we really appreciate your attention. We really appreciate for joining us. Thank you so much. I don't know if you want to say something to the Mexican audience at this time.
No, thank you. Thank you very much for your invitation. It was a great pleasure, and I will be very happy to. Maybe if I go around Mexico, I will email you, and will be very happy to discuss with you with your application of the method in your hospital.
Thank you so much. You are invited, of course, Dr. Thomas. You are welcome in Mexico. And well, this is over. I'm going to finish the webinar. I'm going to speak in Spanish for a while. Gracias a todos por estar aquí con nosotros. Les agradecemos haber compartido junto con el doctor Tomás, quien, como les comento, es un experto a nivel mundial sobre este tema y en general sobre los pacientes neurocríticos. Hemos estado realmente muy contentos y hemos sido honrados por su presencia. Les agradezco infinitamente a todo el público y nos veremos en los próximos webinarios de AMUSCU. Desde luego no te los puedes perder. Thank you so much, Doctor. We really appreciate. Have a nice day. I think it's the evening in France. Is it?
Yes. Yes. Thank you. Have a nice day also. Thank you very much.
Thank you very much for your time, for spending this time with us. Thank you so much.
Bye.
Bye. Bye. Bye.